So I like to start more generally thinking about the hands, maybe ways you haven't thought about them. I don't know. I thought that's interesting. Kant, Immanuel Kant, the philosopher, said hands are the visible part of the brain. And in fact, like I don't teach you guys neuro. I wish I did, but if you look at the motor cortex strip, like if this is the strip of cortex that's dedicated to sending impulses to the body, a huge part of this is just for the hand, disproportionate to the size of the hands. Like there's a teeny bit, like the back. The brain really could care less about your back. Sorry, that's like your favorite body part. And then clearly, 99% of this hand part is just for palmaris brevis. So like, it's like all. So a lot of the brain is just dedicated to sending information to palmaris brevis. Aristotle, the philosopher, calls hand the tool of tools. Yeah, for sure. We use it to greet, and of course, how we greet, is variable culture to culture. I mean, I've been told, like, in the West, when you extend your hand for a handshake, it shows the other person that you're not hiding a weapon. So it's like, it's part, I don't know if that's part of the history. But of course, a lot of parts of the world, you don't greet by handshake. A lot of parts of Asia, here's the Dalai Lama, Thailand, Laos, Burma, you don't greet people, by shaking your hand. So anywho, that's so obviously the hand has an important symbolic function. This is still some of the earliest works of art, handprints on the walls of caves. I've always wanted to see those. It's different ones. Of course, as PT students, we're interested probably primarily in the motor function of the hand, and even there, it's pretty interesting. We can use the hand for power grip, but we can also use it for precision, and we're going to engage different muscle systems there. I think I talked about, maybe we try right now if you guys do it. If you like make a fist, or like you're gripping someone's hand, I think the intuition is that's mostly flexion, but actually you need extensors too. And you now know that the radial nerve is the nerve to the extensor. So in fact, weak grip strength is sometimes a symptom you see when the radial nerve is damaged. That's maybe counterintuitive. I think you would think weak grip strength would mostly follow the right median nerve damage. And then we're going to engage in particular intrinsic muscles in the hand for fine movements, dexterous movements, so things like the lumbricals, the interosseous muscles. When we were talking about the foot, we talked about how those were, in most of us, not well developed, partly because we wear shoes and because we prioritize our hands. But if you don't have use of your hands, you can learn to use intrinsic muscles of the foot. But of course, the hand is also a sensing organ, so a little bit of neuro. If you take a cross section of skin, the outer layer of skin is called the epidermis, and most of that's dead skin cells. It has a protective function. But as you go deeper into the skin, you start to encounter neural structures that play a role in sensing. So really deep, we have structures that sense things like vibration, stretch, pressure. So for example, this is a Pacinian corpuscle, which is pretty deep. And then the receptors we use for our sense of touch, for what we call discriminative touch, like clearly, if I can feel that this is not a smooth edge on this key, I'm using discriminative touch. Then you want to use receptors that are closer to the epidermis, to the surface, of things like Meissner corpuscle, Merkel's discs. We've also got what are called free nerve endings. So these are just nerve fibers going right up to the surface, which we use to sense changes in temperature and pain. So clearly the skin is a sensory apparatus. And so this is showing you like another cartoon representation of this. So some of these, that sense, by the way, is somatosense, right? Somatosensation. Touch, vibration, proprioception, where's their body in space? Pain, temperature, somatosensation, there it is. So some of these receptors are deeper in the skin, some are closer to the surface. If you were blind and you're using a finger to raise the raised lumps on a piece of Braille paper, you're going to be using the receptors close to the skin. You wouldn't be able to discriminate really well the different Braille letter configurations with these deeper dudes like Pacini and corpuscle. And another key feature of somatosensory receptors is they have receptive fields. If you want to, what a receptive field is, the area of, with respect to somatosensation, is the area of skin that if touched, stimulated, activates that one neuron linked to that one somatosensory receptor. Clearly, you want to have low diameter, small receptive fields linked to somatosensory receptors for discriminative touch, right? Discriminative touch. Again, the example, using your fingers to read Braille. You want to have a bigger receptive field for a somatosensory receptor, say, that's just sensing pressure, vibration. To sense vibration, it does not matter that you sense the exact topography of the object that's vibrating your skin, right? So you'd have a bigger receptive field. Then, another key feature of actual sensory systems in the body, not just somatosensory systems, but including somatosensory systems, is some of these, well, let me step back. This is maybe counterintuitive to you if you've never heard this. You might have the idea that neurons are only active when they're stimulated. Wrong. Neurons are active at rest quite often, most of the time. They have a baseline firing rate, and what the nervous system cares about is how does that baseline firing rate when there's stimulus. Do you see what I'm saying? So you got baseline firing rate and some of your somatosensory receptors. You touch the skin, now the baseline firing rate changed, right? That's what the nervous system's interested in. So some of these cells fire a lot right at the beginning of the stimulation and right at the end, but notice they're not firing during the duration of the stimulus. They don't care. It's like the example I use, you put a t-shirt on in the morning. Yeah, you want to know that you put the t-shirt on, you feel it against your skin. But you do not want to waste precious cognitive resources, every 10 seconds throughout, oh yeah, I got a t-shirt on, cool. Yeah, still got the t-shirt on. Yeah, it's still on. Good work, buddy. Waste of time. So these are called rapidly adapting receptors. Now, there are some, though, that do continue to signal throughout the duration of the stimulus. Okay, so we have both types. We have what are called rapidly adapting. And so these are interested in what, a change, beginning and end of the stimulus, and slowly adapting. We've got both types. I would say more often than not, the nervous system is interested in change. It's not interested in static things. Because change is what can kill you. So evolutionarily speaking, it makes more sense to have a nervous system adapted to change, not to static things. So, take a neuro course if you want to know how this touch information in your sensory hand and skin makes its way to the brain. But these first order sensory neurons send information into the spinal cord, and then there are dedicated tracks. This is a really cool story. There's this one right here that you're looking at is a dedicated track for pain and temperature. There's a different track right here in the spinal cord that's a dedicated track for touch, proprioception, vibration. If you wanted to know, itch probably is traveling mostly in this pain temperature track, but there's some people think that there might be a dedicated itch pathway. We don't really know fully. Pretty cool. But you got a separate pain temperature pathway from a touch, proprioception, vibration pathway. That makes it really, really, really interesting clinically. Some people lose pain and temperature. Some people lose touch. Some people lose both. Depends on the condition. Happy to talk about any of this on your own time. So this is just showing you pain and temperature. How would we get that up to cortex? So we send information into the spinal cord. The other, of course, really interesting thing, if you look at this is bizarre. This is not how I would engineer this system. The second order neuron immediately crosses the midline. Now we're on the opposite side of the finger that just was burnt by a pot of tea, whatever it is. We finally make our way up to parietal lobe, primary somatosensory cortex, and only when we make our way up there are we conscious that we had pain and temperature. Do you see what I'm saying? But why would you engineer a system? Why would a system evolve to have sensory information come in on the left and go to the right side of the brain. I mean, I would not do that. That's just really weird. In fact, we don't know. I could talk to you about some theories if you wanted to know, but all of the major tracts in the nervous system are crossed like this. You've heard that if you have a stroke on the left side of the brain, you could end up with paralysis. Where? Opposite side of the body, not the same side of the body. So the major motor tracts are crossed too. Totally bizarre. I mean, if you were making a robot, would you have the left side of the robot brain control the limbs on the left side of the robot? No. I mean, yes, you would. You wouldn't have control. You wouldn't have control the limbs on the opposite side. I can't believe how fast I'm talking. This is cool. This is a record. This is a world record. Okay, so what is this? This is a little map showing you kind of different sizes of receptor fields. Pretty small for like Merkle discs. Merkle discs are a somatosensory receptor really close to the surface of the skin. These are, for example, what that blind individual might use if they're using their fingertips to read Braille. Pacini and corpuscles have much bigger receptor fields. By the way, actually, not exactly what this, I should change the title, okay? What this is really showing you is where these different classes of somatosensory receptors, Merkle discs, minus corpuscles, are highly concentrated. So these things are not uniformly distributed across all of your skin. So again, like, how often do you use the skin on your back to figure out what some object is? Never. Okay, so clearly you're not going to have a lot of Merkel's discs and Meissner corpuscles on the skin of your back. Why would you? But where are they highly concentrated? Your lips, tips of your fingers. Massive concentration there. Pretty cool. Okay. Whereas like Pacini corpuscles, a little bit more uniform distribution, right? Okay. Okay. So that's enough. That's my little intro. A little bit about the hand as a symbolic device, sensory motor device. Okay. So you know how many bones there are in the hand. You can count them on your own time. I'm not going to do it for you. Okay. You remember that there's 8 wrist bones. They're in 2 rows, a proximal row and a distal row. Different mnemonics we've taught you to learn this. We learned also that these carpal bones are not flat. Some of them, especially the ones on the sides, have little processes that stick up. Okay, so like a hook of a hamate, a tubercle of a scaphoid, whatever. Then we can drape a ligament across those. In this case, the flexor retinaculum, and we just made a tunnel for 10 things, the carpal tunnel. Okay, so 2 rows, blah, 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 blah. 5 metacarpals, a whole set of little soldiers, right? That's what a phalanx is a row of soldiers, column of soldiers. All right. And here's some nice little radiographs of these things. You can look at that in your own time. And remember that pisiform is a sesamoid bone. It develops in the tendon. A sesamoid bone is a bone that develops in the tendon. Pisiform is a sesamoid bone developing in the tendon, flexor carpi, nares. And they often increase the biomechanical efficiency of the muscles linked to that tendon. You know, the patella is a classic example. Quadriceps works much more powerfully because of the patella. Okay, so some more radiographs. Check these out in your own time. Okay. So not a lot to say about the joints connecting the carpal bones or between the carpal bones. Okay. Not a huge amount of movement, a little bit. They can kind of assist in the movement that's taking place in the wrist. That's kind of often how they're described, assisting in wrist movements. Let's instead kind of focus our attention on some other ones. Let's think about the carpo-metacarpal joints. And I would say that the first carpo-metacarpal joints, maybe the most important joint in the hand. I'll come back to the slide. So the reason is this is a saddle joint. So you see how the surface on the trapezium looks like a saddle. And it allows movement in many planes, like saddle joints do. And So it's the joint between the trapezium and the first metacarpal. Because it allows movement in many planes, this is the joint that allows for the great degree of ROM of the thumb. Okay. Now, like that's where opposition's happening. Okay. The other carpometacarpal joints, these are all synovial joints. They don't allow the same kind of movement. All right. Let's think about the thumb relative to some other primates. Oh man, I get so many like Gibbon videos on my, I don't know, is it Instagram or whatever it is I'm on. Gibbons are awesome, and I'd like to see a Slowborus. That's just a cool name. But yeah, okay. It's a little bit hard to tell from this picture, but let's just take the case of a macaque. Pretty small digit 1 compared to digits 2 to 5, or whatever this is. However you say that. Even given. So my point is, like, compared to a human, in a human, actually our thumb's pretty long, relatively speaking. The reason I'm mentioning that is it makes it easier for our thumb to oppose the other digits. It's not the case that we're the only primate that can oppose the thumb. You're a gorilla, you're a bonobo, whatever, you can oppose your thumb. But our thumb's pretty long, relatively speaking. And so it's easier to oppose the other digits. That's my main comment there. It is, though, you can see my hand right now is in a relaxed position. It is, pretty relatively speaking, kind of abducted. So compare that to the feet. We talked about the feet. Adaptations for locomotion on 2 limbs, for bipedal locomotion, and all 5 digits in the foot are parallel. So our hand is more evolved for grasping tools, whatever. Okay. Metacarpal phalangeal joints. We're going to finally nail into this more today, because we're going to talk about some muscles that act across those joints, like in particular lumbricals, interosseous muscles. So these are joints, synovial joints, that allow 2 major movements: flexion, extension, and abduction, abduction. Okay, so biaxial, pretty cool. That's what condyloid joints do. They're biaxial, so 2 planes. And then interphalangeal joints, just like in the foot, these are easy, basic hinge, flexion, extension joints. And now we're going to obviously link these bones together with a lot of ligaments. You can see here at the interphalangeal joints, there's a lot of collateral ligaments. There's many places in the body that have collateral ligaments. Okay. We're not going to see this in the cadaver, but there's a really deep ligament spanning the metacarpal distal ends. This deep transverse metacarpal ligament. And are any of you here musicians? Okay, what do you play?
Clarinet and piano.
Clarinet and piano. So I bet in piano, if you're like a classical pianist, you might have, when you were a kid, or you're still doing it, done exercises to try and gain independence of like finger 3 and finger 4, right? It's really hard. And so one of the things that's limiting independence is this deep transverse metacarpal ligament. Okay. Another thing that's limiting independence is these intertendinous intersections. Well, I'll show them to you when we get to it. There's a few things, but that deep transverse metacarpal ligament is one of the main limits. In fact, Schumann or Schubert, one of the two, well, there were a lot, like 19th century composers. One of those dudes, I forget who, they wanted to have more finger dexterity, and they did this crazy hand surgery to try to loosen up, I think, some of these ligaments. I don't think it was successful. Not wise. But they tried. Anywho, okay. We talked about some of these ligaments at the wrist already, like the radiocarpal ligaments, right? Radiocarpal ligaments. And I think on a couple cadavers you can see maybe palmar, radiocarpal ligament, got some collateral ligaments at the wrist too. There's a lot here, I'm not going to describe them all. You can probably have a whole lecture just on the ligaments at the wrist. Okay. So let's just think a little bit about the metacarpal phalangeal joint. So again, this is a pretty cool joint, condylar joint, flexion, extension, abduction, adduction, and some pretty cool collateral ligaments here. We used to have a hand where you can see this. They took it to Davis took it. Oh, you guys too. You know what I want to do? I'm remembering now. On our last lab, we should do this not during finals. Also, can I just say, doesn't it suck that the last time we get to hang out is unless we do a karaoke party? Yeah, we should. Otherwise, it's like the last time we hang out is an exam and you all hate me. That's like such a crap way to end a course. It does that, man. It's a stupid system. So, the last lab before the exam, I want to do a little. I should have been doing this the whole time. We're going to do it. We're going to do a little ceremony to give thanks to the cadavers. Okay? But, we're going to have to say goodbye to cadaver 6 days is taken. I know. Does that suck? Like, that's the best cadaver we're taking. So you could also write hate mail to Davis. Two things. Okay. That's how, like, Davis shows up. Yeah. Yeah. Okay, so flexion, these little metacarpal phalangeal collateral ligaments go taut. So let's try this. So right now, if your fingers are fully extended, metacarpal phalangeal. Now try abduction, adduction. It's pretty easy to do, right? Now do this. Now flex there. Now I can't abduct at all. Isn't that cool? And so what's limiting abduction when your fingers are flexed at the metacarpal phalangeal joint, in part, are those little collateral ligaments. Isn't that cool? Okay. Now, we talked about this with the upper limb. We got these long, check it out. You're like, whoa, man. Look at that. Wow, my mind is blown. We got these long tendons coming in from the forearm, flexor digitorum superficialis, the flexor digitorum profundus, right? And remember, there's that beautiful kind of tendon mechanism. Superficialis attaches to the middle phalanx, and the tendon bifurcates so that the tendon of profundus, which is underneath it, can go past it to the distal phalanx. I mean, how cool is that? But anyways, especially with the fingers, more so than with the feet, you need to have a mechanism to prevent bow stringing of the tendon. So you can see all these annular ligaments here. Typically we describe 5 of them that are keeping those tendons nice and taut and snug. And then there's a set, typically 3, of cruciform ligaments as well. And it's these annular ligaments. I showed you that picture at the beginning that Leonardo da Vinci had in that pit. Okay, so that also that's going to make superficialis and profundus work more efficiently, more powerfully by having those structures. Okay, so that's kind of cool. Now, let's really think too about the extensor hood mechanism. This is a really beautiful piece of engineering. If you look here at the extensor hood, clearly extensor digitorum is coming into it from posterior forearm, but paradoxically, counterintuitively, we got some muscles inserting into it from the palm. So this is an interosseous muscle, and I'll say this a couple times. This guy's inserting into it proximally, and then we got our lumbricals inserting into it distally. And that explains some really cool, also paradoxical things. I asked you this before, but you probably forgot, so I'm going to ask you again. What do you think is the muscle responsible for extension of the dip joint, distal interflexion. I mean, I feel like your intuition is extensor digitorum. No, not really. A little bit, maybe. Because it's going into the hoods. No, the muscles extending out here are the lumbricals. With a little help with the interosseous. That's just muscle on the palm side of the hand. How does that even work physically? Because the tendons are coming up like this to the dorsal side, inserted into the hoods, right? And if you think about it biomechanically, the lumbricals are going way out here. So they're going to be able to act way out here distally. So those are the real powerful extensors at that distal interphalangeal joint, the dip joint. Isn't that cool? So, and here you can see a superficialis bifurcating to allow profundus to go further out. There's some other little minor structures that I'm not teaching you about, these little doohickeys, connective tissue doohickeys that are also attaching to those tendons. Okay. Well, this is a top-down view of the extensor mechanism. And the extensor mechanism really is the hood, and then you got these lateral bands that are part of the complex, which aid in flexion and extension way out there distally. And then here you can see how the interosseous slip is coming in here proximally, and the lumbrical slip is coming a little bit distally, right? So interosseous slip proximally, lumbrical slip distally. Okay. So again, like in particular, and so lumbricals, a little help with the interosseous muscles, really important for fine finger movement. So you were talking about playing piano and clarinet, that kind of thing is a lot of intrinsic hand muscles. Okay, those tendons coming in through the carpal tunnel, in particular flexor digitorum superficialis profundus. Initially, they're in a common sheath, and then they separate out. And here you can see these annular bands. Right. Here we are going through the carpal tunnel. This is the roof of the carpal tunnel, the flexor retinaculum. Right? Okay. And here you can see some of the cruciform ligaments. Okay. Well, you guys can read this in your own time. Think about how often we're flexing our fingers. So it's pretty common to have irritation, inflammation of the tendons linked to superficialis and profundus, right? Okay, so they're gonna make their way into the hand through this tunnel. Here's the roof, flexor retinaculum. You can see in this cartoon representation that the carpal bones aren't flat. So this would be a tubercle of the scaphoid, and pisiform's kind of sitting on top of triquetrum, right? You know what I mean? So. And you might see the carpal tunnel represented differently depending on who the artist was, because there's two rows of carpal bones, right? So depending on if you do an oblique section through there or just a parallel section through there, you know what I mean? The bones that you show in your cross section might be different. So you might have been confused. Like if you look at enough textbooks, sometimes they'll show you these bones, like in this picture from Tima Atlas. Sometimes they'll show you other bones. Again, it just depends on where did they take the cross section. That makes sense, right? And you can see that there's a separate tunnel for ulnar nerve artery, and that has its own roof. So the palmar carpal ligament, with help from the piezohamate ligament. So right, pisiform bone is sitting on top of triquetrum, and then you have a hook of the hamate, and so if you drape a ligament between those, piezohamate ligament, that's also part of that roof of the ulnar tunnel. By the way, you know that's a pretty small tunnel, ulnar tunnel. You can irritate the stuff going through there, just like you can irritate the stuff going through carpal tunnel. So we could talk about an ulnar tunnel syndrome, just like we could talk about a carpal tunnel syndrome. What are the 10 things to remind you going through the carpal tunnel? 4 tendons of flexor digitorum superficialis, 4 tendons of flexor digitorum profundus, a median nerve, and a flexor pollicis longus tendon. Okay. Flexor carpi radialis tendon, not going through the tunnel. Okay. So here's the roof of the carpal tunnel, and I want you guys to look in lab to see if you can find what's called the $1 million nerve. $1 million nerve. Because some hand surgeons probably make that kind of money. Although, you know, I gotta say, props to Mike Tyson. How long was that fight? 16 minutes, right? He tried, right? He's 58. No chance against a 27-year-old. But I think he made over $1 million a minute for that fight. That's pretty damn good. Pretty good money. But hand surgeons make pretty good money too over here. Anywho, so the reason this is the $1 million nerve is because, well, for that reason, but also it's the recurrent branch of the median nerve. It's right about here, popping off. It's popping off the median nerve like kind of like right as it's exiting the carpal tunnel. There's a little bit of variability. It's a teeny, it's like 2 to 3 millimeters long. As you can see, I have multiple cadavers in the lab. And that is a nerve that innervates the thenar compartment muscles. So you want to oppose the thumb. That's really the nerve that's going to do it. Okay. So $1 million nerve is so important because of that branch and median. Anyways, you can see how ulnar is going over the flexor retinaculum. Okay. And this is pretty common. There is a little connector often between ulnar nerve and median nerve. See that? A little connector. And you can really see well the typical dividing line. I would say, and I've talked to hand surgeons, if you on the palmar side, it's more standard. So median nerve hits 1, 2, 3, and a half to 4. Pretty standard. And ulnar nerve hits 5 and a half to 4. And you know, because of that, neurologically, if you wanted to test for ulnar nerve function, you focus on digit 5, because actually motor and sensory to digit 5 is pure ulnar. So you're safe. Like if you were to test ulnar nerve on digit 4, that's just a bad idea. It's a dually innervated finger. And actually these other fingers are multiply innervated. Bad idea, okay? But interestingly, on the dorsum of the hand, like I know the presenters are going to show us the sensory innervation of the hand. You got some standard picks. That is hypervariable. So for a lot of people, it's superficial radial nerve 1, 2, 3 and a half, 4, dorsocutaneous branch of ulnar. But sometimes superficial radial just goes to digit 3. Sometimes superficial radial does all of 4. Hypervariable. Okay. So we talked about carpal tunnel syndrome before. Here's an ulnar tunnel syndrome. So you compress, irritate ulnar nerve as it's going through its tunnel. And now we're finally in a position to think about like all the things that ulnar nerve does. When ulnar nerve comes in, people, it's going to divide into a superficial branch and a deep branch. And the superficial branch is almost purely sensory, although it does innervate maybe the most important muscle in the body, which is what? Ulnar brevis. That's good. All right. The deep branch is the guy that's mostly motor, and it's doing some of the lumbricals. It's doing all the interosseous muscles. It's doing the adductor to the thumb. It's actually doing part of the little flexor to the thumb. So like ulnar nerve really is the major player in the hand, you could argue, with median nerve and close second. I suppose some people would say median nerve is the most important because of that recurrent branch, but ulnar nerve is really innervated with more stuff. Okay, you could argue. Okay. So what would you see in an ulnar tunnel syndrome? Loss of sensation, digit 5, half of 4 potentially. Some problems with these deep intrinsic muscles of the hand. So like, if your interosseous muscles are affected, you can adduct or adduct your fingers. Your thumb is separate. Yeah. Okay. So a lot of things like that. And then you might see what's called clawing of the hand. So let's now do this. Just to remind you, what's the symptom for a radial nerve? Classic symptom for radial nerve injury? Wrist drop and weak grip strength. Okay. Okay. What's one of the symptoms for median nerve? Hand of benediction. So now, remember that hand of benediction. That's not an abnormal posture. That's you ask the patient to make a fist, and they can't make a complete fist. Okay. Claw hand is the classic ulnar nerve side. Sure looks like hand of benediction. This is not what the patient does when you ask him to make a fist. This is just the hand's posture that it gets forced into if the ulnar nerve is damaged. It gets forced into this claw hand. And so like the question is, why are we seeing, the symptoms are over here, digit 4 and 5. Kind of makes sense, symptoms in digit 4 and 5, so you immediately think it's ulnar. But the question is why? Let's step back and think about what do the lumbricals do? The lumbricals, like in the foot, act to the metacarpal phalangeal joint. They flex and extend. It was like bye-bye. And then they, so they flex at the metacarpal phalangeal joint. I'm sorry, they don't extend. They flex at the metacarpal phalangeal joint, but they extend out here, right? Okay. And these two lumbricals are innervated by median nerve, and these two lumbricals are innervated by ulnar. So if you've got an ulnar nerve syndrome, like ulnar tunnel syndrome, you're going to expect to see muscle problems over here. And your fingers get pulled into this configuration because if you look at it, I'm not flexing now at the metacarpal phalangeal joint, I'm extended. So the extensors are pulling the metacarpal phalangeal joint into extension. And I am not extended at the distal interphalangeal joints, I'm getting pulled into flexion, right? So it's the opposite of what the lumbricals do here, okay? Claw hand, does that make sense? Okay, so claw hand, you can see that with ulnar canal syndrome. Okay, so let's now kind of chunk the hand into compartments. If you were dissecting, you would first, and if you look on Friday, my dissectors are getting into the hands. They're going pretty far. And one, they've just opened up the carpal tunnel. It's a pretty nice dissection. You can follow median nerve through, and we're just about to expose the recurrent branch. You can look for that. And then we're looking at some branches of the median, starting to bifurcate out here, common and proper. Pretty cool. You can see all that. But anyways, like the first thing you would see if you remove the skin is none of that. You would see the palmar aponeurosis. So analogous to plantar aponeurosis of the foot. Okay. Some other things, just kind of drawing out here. If you look under flexocarpial ulnaris, you can find ulnar nerve and ulnar artery and stuff. When the ulnar artery comes in, it arches across the hand like that. That's called the superficial palmar arch. So that's another thing you could look for, kind of beneath the skin, actually a little bit below that palmar aponeurosis. So this is the superficial palmar arch coming off the ulnar artery. Just some kind of things you can look for. Another thing you could look for, 2 inches before the wrist, median nerve's out here coming in, wants to go under the flexor retinaculum through the carpal tunnel. But before it does it, it gives off a little branch. And let me do this in black. And this branch goes over the carpal tunnel. So that's the palmar cutaneous branch of the median nerve. That's the one branch of the median nerve in the hand that's not affected by carpal tunnel syndrome. Okay. So, and this is its area of sensation, palm, on the median side, right? Okay. So here's a cross section through the hand. You can see these different compartments, and we'll just start looking at these. Okay. So there's a thumb compartment, 3 little muscles that help with the thumb. There's a pinky compartment, 3 little monkeys, 3 little muscles that move the pinky, and then there's some deeper compartments. Right. And the deepest compartment is the interosseous compartment. These, interosseous, as the name suggests, they're coming right off the finger bones, and they're really deep in the hand. So here we remove the skin. This is that first layer, and you can see that palmar aponeurosis. Of course, if you've done the dissection well, you'll see it in all its glory. Palmar brevis. There it is. Which tenses the skin of the hand. Maybe aids in grip strength. Okay. Palmaris brevis. By the way, that's innervated by superficial branch of ulnar nerve. Mostly the muscles in the hand are innervated by deep branch of ulnar nerve, kind of like in the foot, not this palmaris brevis. Okay, so it's kind of first pass, just opening up the hand. If you were dissecting too, and you wanted to see these proper digital branches on the side of the fingers, you gotta be really careful when you remove the skin. Okay, and so this is actually a former student. This is like 5 years ago. This guy was incredible. I think he won like an arm wrestling competition. I don't know if it was national. Crazy. Did all these exercises he would do to like isolate specific muscles, and he came up with this, which he's trying to make a lot of money on. A barbell, just to help develop palmaris brevis. Pretty cool. And that's it. So you got, like, when I go to the gym, that's all I do. I just do that. I don't do any cardio work. I don't swim. I could care less. I mean, bench presses. That's totally overrated. All I do is work on palmaris brevis. Okay. So, there it is. Okay. So now. Okay, there's the palmar aponeurosis. Oh, and just a little reminder, do you guys remember that? I can do it now. Because Monday you had a Zoom lecture, because it was a holiday. Remember, first layer of anterior compartment. Take your thumbs, do it again. Put it on the medial epicondyle. Drape 4 fingers, but you gotta do it like this. You wanna have 3 of the fingers heading to the palm and your index finger heading to the radius. Because my index finger's heading to the radius, clearly it's doing nothing in the hand. It's going to pronate or teres. My third finger is heading to the thumb, flexor carpi radialis. My fourth finger, pertinent to this, is heading to the palm, palmaris longus. My pinky is heading to the pinky, that's flexor carpi ulnaris. So those are the first 4 muscles, anterior compartment, palmaris longus. Okay, going in to the palmar aponeurosis. By the way, the second muscle that attaches to the palmar aponeurosis is palmaris brevis. So 2 muscles attaching to the palmar aponeurosis. And you can start to see thenar muscles over here, hypothenar muscles over here. Okay, and okay. By the way, just one more time, that branch of median nerve 2 inches before the wrist, pop off and go over tunnel. Palmar branch median nerve. This is interesting. This happened to my father. So it is often men more than women where this happens, elderly folks, and you get contractures involving the palmar aponeurosis and linked tendons. And often, for some reason, digits 4 and 5 are first affected, or primarily affected, or most affected, and they get pulled into flexion. See that? Unknown cause, as far as I know. Some people think it might be autoimmune. So here you can see like early stages, not a lot going on. Now later on, digits 4 and 5 in particular start to get pulled in towards flexion, and then later on massive flexion in particular. And now even 3 and 4 are starting to flex a bit. Okay, so you can grade severity. Anywho, here we are, and we've removed the palmar aponeurosis, and we're starting to see other cool stuff. So my dissectors are starting to do this. You can see these common nerves starting to divide, on the body is pretty cool. And so now we're seeing the thenar compartment, which there are 3 muscles. Some people call these the oaf muscles, both the thenar and the hypothenar muscles, because there's 3 of them on both sides. There's an opponens, an abductor, and a short flexor. So these are the oaf muscles. And on the thumb side, the one kind of draping over the others is the abductor pollicis brevis. The reason it's a brevis is we already saw when we did the snuff box in the forearm, we already saw a long abductor, right? So just to remind you, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus going around Lister's tubercle, and that's the snuff box, and like going over that. Superficial branch, radial nerve. And on my exams, you want to be really specific. You don't want to say radial nerve here. It's not the radial nerve. It's the superficial branch of radial nerve. Going deep to the snuff box is radial artery. You know what I mean? So, anyways, we did that last week. Since we have a long abductor in the thenar compartment, we got a short abductor. Okay, that's the first thing you're going to see. Then you're going to see the ponens and the flexor. Okay, same thing on the PT side. Okay, and in this pic, you can see the roof of the carpal tunnel, and you'll see in the cadavers. It's like check out the new cadaver. Okay, in the new cadaver, it's like a millimeter thick. It's really tough. If you got really severe carpal tunnel syndrome and nothing else is working, they will sometimes do a decompressive surgery or zip or cut right through the flexor retinaculum and then open it up. But anyways, we did that on the body, and then you can follow the median nerve in. You can see what the median nerve is doing here. It is now sending branches out, digital branches out to your fingertips, right? Okay. And right about here, we're going to look for the recurrent branch. And what the recurrent branch is going to do is, it is the nerve to the thenar muscles, is the nerve to the thenar oaf muscles, recurrent branch median nerve, okay? Deep branch ulnar is hitting the hypothemorus. This artistic rendition of the recurrent branch is, it's a little bit misleading. It doesn't look that long usually. It's like 2 to 3 millimeters. Now, I got some dissectors today who are following these digital guys out along the fingers. Okay, so you see that soon. It's pretty cool. Okay, underneath all this stuff is the adductor to the thumb. So this is a deeper compartment, and it's got 2 heads. It's got a transverse head and an oblique head. A couple comments about adductor pollicis. Kind of counterintuitively, like my intuition would be this would be recurrent branch of median nerve, like the other thenar muscles. It is not. It is the deep branch of ulnar arching over. So deep branch ulnar hits the adductor. Another comment about this muscle. So we've followed, radial artery, forearm, going through the snuff box, and what it does here is it pierces the first dorsal interosseous muscle. And then now it's going like this through the snuff box, pierces, right? You guys touch your first dorsal interosseous muscle, it pierces that. Now it's in the palm side, and now it's going to go between the 2 heads. This is the oblique head, this is the transverse head. Now it's going to go between the 2 heads and adductor pollicis, like that. So, and as it exits these 2 heads, and now it's in the deep palm, this is called the deep palmar arch. So, I talked about on the palmar side, ulnar artery comes up and arches across. So on the palmar side. Ulnar artery comes in and crosses like that. So that's the superficial palmar arch. You'll see that in the bodies. But there's a deep, so there's a deep arch. So these two arches connect, just like we saw the foot. So superficial palmar arch is coming off ulnar artery. Deep palmar arch is coming off radial artery. And these two arches, these two blood arches in the hand, the anastomosely connect. So that's another thing to think about with adductor pollicis. Hand movement. Okay, so notice how right now my fingers are in the same plane. Okay, so if I move my thumb out like that, that's extension. If I move my thumb like that, that's flexion. If I move the tip of my thumb to the tip of my fingers, that's opposition. This is keto. Now watch. If instead I move my thumb perpendicular to the plane of my hand, that's abduction, adduction. So be careful. Okay. Flexion, extension, abduction, adduction, opposition. So this guy is doing this. Okay. Abduction. Okay. Let's take a side trip just for a second and think about how important the thumb is. That's obnoxious. Think about how important the thumb is neurologically. So, okay, we got extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus. The snuff box muscles. These are going to the thumb. Anyone remember what the nerve is?
Posterior os.
What's that?
Posterior os.
Good. Posterior interosseous nerve, which is a branch of the radial. So that's one nerve going to the thumb. Now on the front, we got a long flexor pollicis longus, and so there's 4 layers. Anterior compartment. First layer is 4 muscles. We'll just talk about that. Second layer is flexor digitorum superficialis. Third layer. Anyone remember how many muscles? 2. Flexor pollicis longus. Flexor digitorum profundus. What's the muscle in the 4th layer? Pronator quadratus. So, if we're deep in the forearm, what's the nerve to flexor pollicis longus? Huh? Anterior interosseous. Oh, yes. Okay. Okay, what else do we got? We got the oaf muscles. What did we just learn is the nerve to the oaf muscles of the thumb? Current branch of median nerve. And there's one more. Adductor pollicis. Then what's the nerve?
Deep branch.
Deep branch ulnar. So 1, 2, 3, 4 nerves to the thumb. That is the good news. You don't want to have a median nerve damage because you can lose a lot of thumb movement, in particular opposition via anterior interosseous branch, but via recurrent branch. But the good news is there's other muscles, there's other nerves that can innervate muscles to help recover some function. So if you had a median nerve damage, depending where it is, obviously, maybe this could help, right? So that's kind of the good news. So here's that. Radial artery on the dorsal side, going to the snuff box, piercing the 2 heads of adductor pollicis and making a deep radial arch. Okay. Wow. So a little more nuance. If you look at this table, look at the flexor pulse brevis. Right here, T head, ulnar. Okay. So a little more nuance. Okay. Okay. Movements of the thumb. I just demonstrated that. Yay. Okay. We also got 3 hypophenar muscles. This is interesting. Maybe there's a comparative anatomical reason for this. I don't know what it is, though, if there is. Why this is called flexor digimini brevis? Maybe just because it's a little teeny muscle, but there is no flexor digimini longus. Okay, there is no dedicated flexor to the dig 5. So weird. Maybe they're just using this term here because it's a little. Here they are. More details. This is one reason I like TEMA, these little muscle attachment schematics. I think are pretty cool. Pretty complex set of attachments, which I'm not going to go over. But okay, now if you remove the blood vessels and the nerves going through the carpal tunnel, here they've done that in this picture, even though they've left the roof of the tunnel there, you can start to see some even deeper structures. So now we're going to see some analogous things to the foot. So for example, there's some muscles in the hand that come off tendons, just like in the foot. So here you're looking at flexor digitorum profundus coming through. And lo and behold, we got some lumbricals coming off profundus. Etc. So more on that in a second. Let's take a break, come back.